for sticking with us to speak to us about an emerging trend of mental health and its challenges. We are proud to introduce Dr. Mustafa Abdulhusein. He was born in Sudbury, Ontario in Canada. His father is still practicing GP. He went to medical school at Ross University and graduated from the University of North Dakota Psychiatry Residency Program in June 2018. He has been practicing in the outpatient setting, but over the last year has been doing consult liaison work in Fargo. Welcome, Mustafa Bhai. It's a very important topic, especially over the last 2 years. Thank you for joining us.
Expecting a round of applause, but that's all right. No, that's okay. That's all right. That's okay. I can't blame you guys for wanting to go to the other talk. I personally was interested in hearing what they had to say about private practice, but here I am. So thank you, Alifia Ben, for that kind introduction, really, and really thank the SBMA for inviting me and for having me here. I don't know about you guys, but I think this entire conference so far has been really well organized. So really, round of applause to you guys for sure. I think the devil's in the details, and I'm sure a lot of organization has gone on for weeks, if not months, on end. I don't know about you guys, I didn't realize that these QR codes were actually your contact information. When somebody showed me that, I was like, wow, that's really impressive. So, just the things like that. Hatim Bhai Fatihi, obviously, he's not here, but he did a lot of work, and he sends us all these messages. So, first things first, Maulana Haq dua kariye ke Khuda Ta'ala ka Maulana Umar Sharif ne ta roze qiyamah daraz and daraz kare. Ameen. And so if you don't know me, if we haven't met yet, I'm sorry you haven't had that pleasure, but so my name is Mustafa. I'm a psychiatrist. I work in Fargo, North Dakota. People ask me why Fargo, and I say why not Fargo. So Fargo is a beautiful city. It's a small town. I did my residency there, but some of you may know my father, Sheikh Dr. Abbas Abdulhusein. He works and practices in Canada, and so he's done some of these talks before. And I asked him his advice, and I said, any advice for me? He said, yeah. He said, don't make any stupid jokes. Is the first thing he told me. So on that note, the SBMA wanted the best and the brightest to come and talk to you this afternoon. They weren't available, so they asked me to come in and fill in. That's my contact information. I didn't realize they were going to give us these fancy QR ID codes, but anyways, there it is. So just by a show of hands, please don't be shy. Please raise your hands really high so we can all see it. Who has experienced any form of anxiety in the past? Okay. I'm feeling a little bit of it right now, to be honest. Okay. Who has experienced any form of depression in the past? Yeah, perfect. Excellent. So you can see, just around the room, it's pretty common. Maulana farmawe che ke apnu physical health and mental health beweni gani fikar hoye che Maulana ne apne suno se waz ma ke suicide koi divas koi war sojo bhi nahi ane Maulana farmawe che ke ek choti musibat ma si tami gani moti musibat ma fasai jaso. So I think it's really important. Maulana ne gani fikar hoye che. So again, this topic I think is quite important. I'm not going to get into the the religious aspects of mental health and the faith-based aspects of mental health. Obviously, that's important, but I think that's a discussion for another day. But obviously, Maulana apna samaj che ane whatever we're doing, Maulana khushi wasti kariye che. Okay, nobody has offered to pay me for this talk, but it's still not too late. I'm willing to accept any form of payment, but I don't have any conflict. So today what I'd like to talk about are a few things. So, okay, just disclaimer, I should maybe go back one slide. They asked me to do this talk. I wasn't 100% sure what they wanted out of me for this talk. I'm sorry, but I really wasn't. So I tried to think about my audience, you guys, and I tried to think about, you guys are medical professionals. You're obviously leaders in your local jamaats, and you're likely going to be going back and, sorry, I think it's really annoying. Can I have that? Yeah. Probably don't even need this, but here we go. Okay, so I try to imagine my audience. You guys are obviously leaders in your Jamaat, so I think what I wanted to do is give you guys a little bit of a review and a little bit of an overview of mental health topics, especially depression, anxiety, special populations, especially the elderly, adolescents, talk about postpartum care. I think that's really important, gets left behind oftentimes. In case we need to do a risk assessment for suicide, that's our biggest thing in psychiatry. and we're always worried about safety. So I really wanted to talk about those things. And then don't worry, there is a slide on the end about emerging trends, which is the title of the talk, but we'll get to that at the end. And then I've left time at the end for discussion. I'm really glad that they gave you guys snacks because it's the last presentation of the day. So I'll try to be conscious of that. And I know we're getting, it's getting long. Okay. So when I think about mental health in our community, especially Apna Dawadi Bora community, we're a small community. We all know one another, or we know somebody who knows somebody. So I think if there's one takeaway point, it's that mental health in our community, and I think Lulua Ben, you already kind of alluded to this with your talk about adolescence. The fact that I think a lot of our people who struggle with mental health issues suffer in silence. And that's because of the stigma of mental health. So we still have a stigma with mental health. I know it's getting better. I know the fact that I'm having this conversation with you is evidence that it is getting better. But think about mental health. We don't see it. So if you don't see it, people often don't talk about it. And it's often, goes, and I think the idea of people who struggle with it, if they have depression, anxiety, for example, may end up suffering in silence. So just being aware of it, I think, is the number one thing. I'm just, sorry, I have mint in my mouth. So unprofessional. Okay. Why do we have the stigma? Off the top of my head, these are some of the reasons that I came up with. I don't have any studies, and Lulua Ben was talking about that. We don't have any surveys. We don't have any evidence that shows why people in our community are reluctant to talk about it. So these might be some reasons why we have this stigma. We have a small community, as I said. We all know each other, and I think we think about our reputation a lot. And we often think about mental health as a weakness. So, why is that person having depression? He must not be able to handle it. Or why does she have anxiety? She obviously, there must be something wrong with her. People might think of it as a self-inflicting punishment, that I deserve this, or I should be suffering, I should be suffering through this. I think personally, I struggled with low moods and depression, I would say, when I was in medical school, right? So in medical school, we're often in high stressful situations. We're maybe not doing as well as we thought we would do. And so in those scenarios, you'd often think, oh, it's going to pass, it's going to pass. It's just this phase of my life, next 4 years, and then it's going to, it's going to be better. And then the secret that, I have to keep this to myself, and nobody will help me, nobody will support me. And I think it all comes down to this idea of ke logo su kaise. If people found out, they're going to talk about me, they're going to think differently about me. So that's the main thing when it comes to stigma, I think, in our community. Okay. Oops. So the idea that mental health isn't an island by itself, but it's very closely related to physical health, to overall physical health. I don't have time to go over all the data and all the studies, but obviously there's a huge link between mental health and physical health. It has to do with your rapport with the clinician, how likely you are to engage in appointments, how likely you are to take medications, how likely you are to follow through with the recommendations. And so if your mental health isn't in a good spot, likely your physical health isn't going to be well controlled either. Fancy slide, you have to have arrows in your slides, right? You have to have some arrows pointing to something else in your slides. So this is that, check mark for me. But basically, cardiovascular health and depression and anxiety and PTSD and the relationship between them. There's physical reasons, and then there's biological reasons, and there's psychosocial reasons why those two are related. So poor control of one directly relates to the poor control of the other. We had a talk earlier about pain and pain management, and so we know that pain, for example, is an inflammatory illness, so is depression, right? So those two things are very closely related as a circular relationship. Okay, most of you will know this. I know I'm talking to a medical audience, but again, if you're taking this back to your jamaats and you're taking this back to your people that you're going to be seeing, I think it's better to have a way to talk to our people, our mu'mineen about this. And so depression is not just sadness. It's not just feeling down or depressed. The DSM-5 has very specific diagnostic requirements. So more than 2 weeks, a majority of the time, at least 2 weeks, excuse me, majority of the time for those 2 weeks, majority of the day for those 2 weeks, having 5 of 9 of SIGI caps. That's a depressive episode. And I still use SIGI caps as a mnemonic for the symptoms. We'll go over those in the next slide. And it's really impairing. So I just wanted to mention that it's not just feeling down or depressed. I don't think I don't think the impression is that people in our community are minimizing or maximizing their symptoms, rather. I think, if anything, they're minimizing their symptoms. So just be aware of that. Okay, so again, this is just a quick slide about the signs and symptoms. Still used if you're not familiar with the mnemonic, but SIGI CAPS is sleep, interest, anhedonia, guilt, energy, concentration, appetite, psychomotor changes, and suicidal thoughts. And so, and then, obviously having depressed mood is part of the criteria. What do I want to point out of that slide? It usually, to meet criteria, it has to cause some sort of impairment, and it's not medically explained by another illness. For example, any idea? Perfect. Hypothyroidism. Anything else? Okay. Anybody else? Besides the psychiatrist, anybody else? Vitamin D deficiency. Good. What else? Well, maybe before penicillin. Wilson's disease. Okay. So zebras now instead of horses, right? Iron deficiency, right? Iron deficiency anemia, right? Fatigue, low concentration. What about, I don't know, I don't want to stereotype, but somebody who's overweight, snoring, not sleeping very well, right? So OSA, right, is quite common, underdiagnosed, type 2 diabetes. So there's lots of things, as you said, and this is just off the top of your heads. Very good. Okay, Lulu Ben, again, I wish we'd kind of coordinated because, I wish I knew what you were talking about. But anyways, PHQ-2, she mentioned it. Those are the actual questions. PHQ-9, you've heard of that before. It's maybe too detailed to do routinely. So PHQ-2 is just a brief, really screening questionnaire. So you don't have to be a psychiatrist to ask these questions. But the reason that questions are so important is because that's how I make a diagnosis. So questions are really important in psychiatry. I don't have a blood test, I don't have a brain scan, and so that's why questions are so important. So being familiar with what types of questions we're thinking about, I think, is really helpful. So for example, during the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? And then during the past 2 weeks, have you often been bothered by having little interest or pleasure in doing things that you previously enjoyed? Other screening questionnaires, as I mentioned, PHQ-9 and the Beck Depression Inventory. The Preventative Task Force in the US and then Canada, those are their recommendations. I'm not going to read them out, but essentially ask people about depression. That's the takeaway point there. In the US, they recommend everybody, but then you should have mechanisms in place to follow up on those screening questionnaires. In Canada, they recommend, if they have a family history or symptoms of depression is who you should be screening. What do I want to mention about that? So I think the important thing is that if, for the USPSTF is that appropriate follow-up. And that, I think, is one thing we can work on in our community. Okay, speaking of which, so if we wanted to figure out who has depression and how we should go about, finding that out, we could do targeted or general population screening. Again, mentioned already about ITS and the questionnaires that we can do and the data update drive. Biggest issue, again, is stigma and the confidentiality. And what are we going to do with that data, I think, should be something we should be thinking about. But these are some red flags. So have you been suffering with difficulty sleeping? Have you been suffering with air energy? Are you having lots of pain that's not controlled by your medications? Are you having some major life stressors? And then are you having any physical symptoms that nobody is really able to diagnose? Any questions so far? Any concerns? Great slides. Anything? Mm-hmm. Sure. Sure. That's a great question. Thank you. I wasn't going to bring that up, so thank you so much for asking that. First of all, I think the setting would be most important, right? Paying attention to the setting. So if somebody's talking to you after namaz, in the masjid, maybe not the best session to be having a sensitive conversation about their mental health and their depression. I know this from personal experience, right? People approach me and they want to talk to me and they want a medication recommendation right there, but I need more information and it's not the right. So the first thing is the right setting and also making sure that you've set aside some time to talk with them. So if you're in a rush, right, if you've got 20 minutes or whatever, that's not an appropriate time to be talking about sensitive issues like mental health. That's just so you, I mean, that's the first step, I would say. But let's say they're going on, they're rambling, and they're not really getting to what you want to talk about. That's, right, what you're asking. So usually what I do is I usually give them about maybe 5, maybe 7 to 10 minutes at the beginning, and I let them talk about whatever they want to talk about. And I try to get as much information as I can from them. And then usually in that time, I'm either jotting notes or I'm taking information that I'm listening for stuff that I'm going to need later on. And then I'll say, I'm sorry, if they're still talking and I'm not getting anywhere and they're talking to me about something that's irrelevant, then I'll usually interrupt them and I'll say, I'm sorry for interrupting, but I really want to focus on what's bothering you today, and maybe we can bring the conversation back to what I think is important. And from there, they usually are usually fine after that. Is that okay? But no, go ahead. More, yeah. Sure. Sure. I usually, yeah, so in the clinic they give them a piece of paper, a PHQ-9 G87, and then on the back they have like, you know, other questions and stuff, so they bring that into me. For me, as I said, I usually let them talk about what they want to talk about, and then I would say, okay, I have these symptoms that I have to get through, there's some questions that I have to get through, and I just go through those, and those are robotic. But especially in an outpatient setting, you have limited time, so I do have to get through those questions, and I need that information, often for billing and often, you know, for diagnoses as well. Does that make sense? Yeah. So I give them the heads up that, hey, this is going to be robotic. I just need short answers, right? So if you're telling me about your sleep, I don't need to tell you, you know, what you're doing when you're brushing your teeth. I don't need all that information. Just give me the number of hours you're sleeping and how your sleep is. That's kind of what I want to know. Concentration is good or bad, horrible, you know, that sort of stuff. Okay, so switching gears, so that's why I wanted to ask for questions, but we're just talking about anxiety now. So anxiety, fikr, I think everybody knows that. List of symptoms. Criteria for GAD or generalized anxiety disorder is greater than 6 months, and so it's a bit of a longer time frame. It's probably the most common type of anxiety disorder we see, but there's other types of anxiety disorder, including anxiety disorder unspecified, for example. There's different types of like PTSD and OCD, and those are technically different chapters in the DSM-5, but I still see them as anxiety disorders. Specific phobias, I would suggest that, I think, if I'm not mistaken, that's the most common type of anxiety, actually, in the whole population, but it's the least treated because it's not that relevant, right? I mean, how often do people have snakes and heights and things like that? So it's not that relevant, but anyways, in the clinical setting, GAD is the most common. So these are some of the symptoms. Feeling fatigued, muscle tension, difficulty concentrating, and then can't control it. They can't just shut it off. So it's affecting different parts of their life. Okay, some things that contribute to anxiety. So oftentimes it's about the unknown. And a lot of this stuff got worse with the pandemic, right? Because they're not sure. In healthcare, we're not sure what's going to happen. What's the next variant that's going to come out? What's the next masking guideline that's going to come out? What's the next recommendation on so-and-so that's going to come out? So I think that's really important to keep in mind. Health-related stressors, important. Financial concerns, academic concerns. In our house, it's mostly madrasa is our biggest concern, and IBS, I'll be honest. And so that's the biggest stressor, but, you know. So then that brings me, good segue, pat on my back. Any questions before we talk about children and adolescents? No? Okay. So children and adolescents in our community, in the general population, it's still underdiagnosed, it's undertreated. There's certain risk factors for children to develop mental illnesses. Obviously, if they have a family history of mental illness, if they have a personal history of mental illness, if they have had trauma, if they have prenatal exposure to substances, if they have stressful life events at school or at work, then they're more likely. Little children classically have reluctance to go to school. They have unexplained physical symptoms, headaches, stomach aches. So those are things that you should be, you know, for example, for separation anxiety disorder, that might be something to keep in mind. I just wanted to say that there is, and then next slide. So sorry. So this is anyways, these are some resources that I wanted to share, but I'll come to those in a second. Okay. I don't have a lot to say about adolescents and children, except for the fact that Medications are often not the first line. We often try to use therapy first if we can. There's obviously a difficulty with access and a difficulty with finding providers. I think generally, even not Dawoodi Bohra population are reluctant to treat with medications. So I assume that's going to be very, very prevalent in our community as well. Nobody wants to load little kids up with antidepressants or antipsychotics or whatever. So just, be aware of that. Okay, talking about pregnant women, women who have given birth. Again, an undertreated population, and they're less likely to receive mental health treatment than non-pregnant women. And it can cause quite a bit of suffering, so I think it should be on your radar when you find out somebody who is pregnant. And it causes suffering for them, and it can cause suffering for the baby, for the fetus. So it can, obviously, we don't think that our women are using substances and things like that, but the data that we have says that it increases the risk for that. It can increase the risk for stress in the house, with their husband, other children if they're there. So what are some barriers? Why are they undertreated? They think that because of a reluctance to engage in treatment, like they're gonna just put me on medications. They may not have access to it, and then the stigma still, even not Dawoodi Bohra community, still raises its ugly head. First line is often CBT and psychoeducation. And then the treatment options depend on the severity and the diagnoses, of course. But as I mentioned, medications are treatment options. I'll come to medications later on in the talk. Okay, next slide. Medications in pregnancy. So most commonly we use the SSRIs. They're mostly are safe. I try to stay away from Paxil or paroxetine. But I use Prozac, I use Celexa, I use Lexapro. Don't have any randomized double-blind control trials. I'm sure you guys have had all these talks with your patients. I'm not reinventing the wheel here, but these are things that we should be aware of because there is going to be that reluctance that mane dawa na tilevi or mane kai baby ne khai thase, kai kharab thase, or things like that. According to what we know, there is no bad stuff that happens to the baby because of SSRIs, except for Paxil, which there might be an increased risk of cardiac malformations. But there is a slightly increased risk of persistent pulmonary hypertension of the newborn, and theoretically postpartum bleeding can also go up because of platelet aggregation. But there's no long-term bad stuff that happens to the baby, which is what the women are mostly concerned about, the mothers are mostly concerned about. So that's why it's always a risk-benefit analysis. You're suffering right now for something, you're definitely suffering right now, and just be aware that what you're worried about with medications probably won't happen, so yeah, go ahead. Yeah. So definitely, genetic risk factors have a place in treating depression, right? So if your parents had depression, you're more likely to have depression. I can't remember the exact number, but I would say it's on the order. It depends on the diagnoses, right? Just depression, just postpartum depression in pregnancy. Off the top of my head, I'm not 100% sure. But if you are, I think if I was to answer that question in the clinic, I would say it would depend on the severity of your depression during your pregnancy, right? Why? Because if you're severely depressed, you're more likely not to, you're more likely to be malnourished, you're more likely not to engage in health and antenatal care, you're more likely to not take your medications, poor outcomes, right? So that's what I would suggest, depending on the severity of symptoms. Maybe mild depression, maybe not. Very increased risk. Any more comments, questions? Okay. These are resources. I think they'll have access to all these slides and stuff after. Do you know? You guys know? Yeah, they will. So these will be on the slides after. But the last one I really wanted to highlight. I really like it. It has the interface is really nice. It has evidence-based pictures and care and all this sort of stuff, and it's good for patients. Obviously, not everybody's going to have access to all the other stuff like UpToDate, but these are the resources that I'd like to use for when I'm talking about breastfeeding and using medications in pregnancy. Okay. Another slide on depression and the postpartum population. I don't want to harp on this, but I do feel that they are kind of forgotten. You know, the women are forgotten, unfortunately. So I just wanted to bring that up to everyone's attention, that postpartum depression is a big deal. It does affect women. It can happen. It can happen to anybody. It doesn't matter who they are. It doesn't matter what religious background they are. It doesn't matter what they do. It can happen to them. And in severe cases, it can lead to psychosis as well. So obviously scary stuff. What else have I just can't read it. I'm just sorry. So medications and breastfeeding, what do you guys tell your patients? It's okay. Yeah, it's okay to do it. What are their concerns? It's getting to the baby, right? Which medications get passed to the baby? Okay, good. What else? It's on the slide, but you don't have to look. Yeah. So all of them, right? So all psychotropic medications are excreted in the breast milk, right? All to the same degree? No. Good. Why is that? Because it depends on the drug, it depends on the formulation, it depends how it's metabolized, it depends on the individual mother, how quickly she's metabolizing it. Before, actually, I was recommending that maybe the mother should pump and then feed after, you know. But they actually, when I was looking up this talk, they didn't say that you have to do that. They didn't say that you have to pump and dump. I think that was what they used to say. But now they don't recommend that you have to do that. So something to keep in mind. What else? The concentration of the drug that gets passed into the breast milk is a lot lower than what the mother is taking. So that's reassuring. If the mother was taking a drug during pregnancy, the most common effect on the fetus is discontinuation syndromes or symptoms. So no long-term effects, but you know, that's why another reason Paxil might not be a good idea, because of the short half-life and the withdrawals from it. Okay, another neglected population, I feel, in my opinion, are the elderly. Yeah, go ahead. Yeah, yeah, please do, please, yeah. Yeah. Yeah, yeah. So what would you say? Sure. So first of all, the question I would want to know is how severe it was before, right? That would help me guide them. And then I'd ask them what they wanted to do, right? Given the fact that antidepressants do take some time to work, right? They take maybe 3, 4, 5, 6 weeks to work, and then to get to an effective dose. So that's what I would kind of let them know. Obviously, well, not obviously, but if somebody had depression during their previous pregnancy, they're at increased risk of having depression during subsequent pregnancies, just like they have increased risk of gestational diabetes. So I would recommend that they strongly consider the possibility, especially if they took a medication last pregnancy and it helped. That's what I would say. If possible, get out of the first trimester if you can, but you don't have to. I'm just saying, you know, first trimester is when all the organs are developing, cardiac, all this sort of stuff. So if they wanted to wait till the first trimester and then reevaluate, that might be another strategy to take it as well. Is that okay? You sure? Yeah? Bye-bye. Perfect. Perfect. So just in case nobody heard it, I think you're recording, but 2, 4, and 6 months, pediatricians screen moms for depression at the well child visits, right? Yeah. Okay. Yeah. Yes. Mm-hmm. 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 Sure. Sure. Yeah. Well, I I didn't put the source on there, but that's from Up to Date. so I would trust it. And I didn't look into what they meant by some sort of mood disturbance, but I would suggest that it's a high number, just based on the fact that I think it's underreported and it's underdiagnosed. So, yeah, please. Sure. Well, I think this number is talking about the postnatal blues as well. I think it's talking about any mood disturbance. And you're right. Actually, the first 48 hours is the highest risk because of the hormonal changes after pregnancy. And we think that has to do with postpartum depression. The sudden drop in estrogen and luteinizing hormone, maybe? Anyways, no. What is it? Progesterone, thank you. Yep, sorry. Well, just because it happens to everybody, I don't know if it's normal, but, you know, because I'm a psychiatrist, I want everybody to get treatment, right? But, but, sure. It's expectable. Yeah, it's expected. Sure, absolutely. Yep, yep. Sure. Yep. It can get better, but it can also get worse, right? So that's, I think that's where that 10 to 15% number comes, right? Because that percentage can get worse. So that's the only, yeah. Sure. It's a risk factor, right? So bipolar disorder is a risk factor for postpartum psychosis. So that's something to be aware of for sure. And so if you know of somebody who has bipolar disorder, certainly, you know, let them know that, be aware of this. Be really, my advice to everybody, including not just postpartum depression, not just bipolar patients, is just be protective of your sleep. I think that's the biggest thing, and I think that's going to be the biggest disruption after somebody gives birth. Especially, you know, and so that's why it's so different, right? The numbers may be so different too because the baby is different, right? Everybody has a different experience. Some babies are really good. My baby, not so much, you know, but yeah, I don't know what, but it's the straw you pick, I guess. Geriatric psychiatry. So these are determinants of good health. So, oh my goodness, really? Oh my goodness, all right. So there's the 5 minutes. I'm about halfway through, so we'll go through this really quick. A lot of reasons for elderly patients to be depressed. Be aware of that. Great. Effects of the pandemic. Everything got worse because of the pandemic. Nothing got better because of the pandemic. That's the takeaway point for here. I'm really sorry, guys. I should have been aware of the time. I apologize. If you guys have questions, please ask me later or get in touch with me. When I do a risk assessment, the highest, what's the most predictive thing for somebody to harm themselves? Right, previous history, right? So that's the number one thing. If you can take that away, obviously, if they have means, if they have firearms in the home, those are really scary for us as well. I've touched on a lot of these already. We've talked about medications. There's different types of therapy. I have a few slides on those. There's different types of exercise that you can prescribe. For example, aerobic exercise 3 times a week, at least 30 minutes. Different types of diet. I have a slide on that. Bright light therapy, especially for those who live, you know, who aren't fortunate to live in Houston or Dallas, but who live in Chicago or North Dakota. And then family support as well. And LA, yeah, exactly. You always don't need bright light therapy. This is the diet pyramid, and this is a Mediterranean diet. Building your diet with people around you, number one, and then starting with the stuff that you don't want to eat, and then ending up on the stuff that you do want to eat. Mine is flipped. I don't know about you guys, but mine is the other way around. So I start my meal with sweets and meats, and then work my way to the vegetables. Okay. Interpersonal therapy, different type of therapy. Not everyone may be aware of it. Everybody has probably heard of cognitive behavioral therapy or CBT. IPT is a little bit different. It's split up into different types of sessions. It's really good for people who have experienced grief or loss or are going through a shift change in their life. So that would be something to think about. I don't think that most of you are going to be providing this type of therapy or doing this therapy, but letting them know that, hey, this is available to you. Mindfulness therapy. Mindfulness is essentially that the short of it is paying attention to your thoughts and what's going on in the moment without judging it. That's the essential idea behind mindfulness. If you guys get a chance to check this out, this is a guided meditation or a mindfulness session on YouTube. I've recommended it. A lot of people find it helpful. It's called Leaves on a Stream by this lady, Naomi Goodlet. She kind of rehearses it, and it's just a really nice one. Okay, I won't really go into this too much detail, but these are some newer medications. There's Vraylar. I'm not sure if you guys are familiar with it or have used it, but it's a newer antipsychotic. It works on D3 more than the other ones, and it's approved for augmentation, but also for bipolar and schizophrenia. Then there is Trintellix, which is another antidepressant, a newer one that has come out. It's a little bit maybe a little bit better tolerated than its predecessors, but that's what the drug companies want us to think. So then the other ones are ketamine. There's a lot of sort of people are wondering about ketamine, and there isn't any approval for it just yet. It's off-label, so everybody's using it off-label right now. Whoever's using it. But it's not our first-line treatment option. Why? Because you have to get it infused, you have to go to a clinic, it's short-lasting. It's usually in our North Dakota, that's given by anesthesiologists, so we're not sure, how good they are doing with their mental health, diagnoses and that sort of stuff. And it's expensive, that's the other thing. It's not covered by insurance. It's $500 to $800 an infusion. Okay, we've already kind of talked about all this stuff. I'm sure you guys are already aware of it. We had a really good talk this morning from that doctor, so I think that we don't really need to talk about it today. These are some interventions that we could do to help people with mental illness. So obviously I've talked about the stigma, I've talked about how confidentiality plays a part. People aren't willing to talk about it, so then suggesting these other ways that they could go about it. For example, apps. I have a slide on the next slides about the apps. We could talk about going into check-ins, doing a check-in, just sort of a buddy system. We did that during the pandemic, our group, our psychiatry group. So you had a buddy who you would check in maybe once a week, maybe a couple of times a week, and just give him a quick phone call. Hey, how are you doing? That sort of thing. So maybe we could do something like that in our Jamaats, where not necessarily your friend group, but somebody different, and you just kind of develop those relationships that way. Journaling is important, and then ITS, could we use that as a more effective tool for mental health? Maybe some of you use it. I know I have a Fitbit, so I know on Fitbit app you can record how you're feeling. Some of the watches now tell you if you're stressed or not, or you can tell the watch if you're feeling stressed at that time, and you can kind of track that over time. Okay, these are just some screenshots of apps that people can use. This is Mood Fit. This one's good for patients who have a lot of anxiety, and so this is something to think about. Calm, you may have heard of this one. What's that? Lifetime member of Calm? Yeah, exactly. So there you go. Mood Mission. I'm not familiar with this one, but this one, when it's just one of the ones that come up, and it's evidence-based, so that's important. This one, I know it looks childish, but apparently, according to what I found out, this is adolescents and college students really like this one. What is it called? It's called Finch, right. Okay, if you're not in psychiatry, if you're not in mental health, one of the questions you may have is when should I refer, when should I reach out to psychiatry or a psychologist or a therapist? There's no right answer. There's lots of different things that go into the decision to do that. It has to do with individual providers, individual patients, access to somebody that you can refer to if they're requesting it, clinical case, clinical scenario, the diagnoses. So, okay, promised I'd get to it. This is the talk. But it's only one slide, so bear with me. So the emerging trends in psychiatry. How many of you have heard of blood tests for mental illness or genetic tests for mental illness? Hands up. Yeah, so some of you have. In our group, we use GeneSight is the name of the company that they use. And what they do is they take a swab of your saliva, and then they just test your enzymes, right? So which enzymes that you have, your CYP450 systems, and we know which ones are metabolized, which drugs are metabolized, and then based on that, and then which receptors you have, the homogeneous, heterogeneous for the serotonin receptor. And without getting into too much detail, but there's green light, there's yellow light, and there's red light, so it's really easy for patients to to kind of read it. And it also goes through all the different classes of psychotropic medications, antidepressants, anxiolytics, antipsychotics, mood stabilizers. The main takeaway for me when I'm talking about them is they're not very expensive. They used to be. Most insurances actually do cover them now. But the main thing is that the expectation shouldn't be that this test is going to tell me which medication I should be using. Because they often come to me with that expectation. Like, you know, doc, I've tried all these different meds. I just want to test. Just tell me which medication to use. It's not quite there yet. It may get there, but, you know, it's not there yet. Sorry, I'm running over time. Okay. So AI is the way to go. If your kids or anybody is planning to get into medicine, tell them not to and tell them to do artificial intelligence because that's the future. And so that's the book that if you can read it, definitely read it. TMS is transcranial magnetic stimulation. That's going to be a really, I think a lot more clinics are going to start having that. Social media is really big. I don't know about you, but the first thing I do is check WhatsApp in the morning, and I shouldn't, but I do. And so we all have bad habits about that sort of stuff. The American Academy of Pediatrics, and you can kind of correct me on this, but I think it's still 2 hours is the limit for children, right? Per day for screen time. And so I blow that out of the water before I get to work, right? But above 2 years of age, okay, exactly. So if it's not good for your kids, it's probably not good for you. Okay, so it's just a summary. We want to alleviate stigma as much as we can. Please, please try to do that. Please don't be judgmental. Please, you know, be confidential. Please don't talk about it, even to your spouse if you can avoid it. Don't tell them that this person abin or abay manawata awat kariti. Oh, it's a secret, right? It's a secret. Don't tell anybody is how secrets get spread, right? So please don't do that. You know, as Abdullah mentioned, we're still medical professionals in all the settings we do, and we can get people better. Then it's just going to be a snowball effect. You know, I went to this person, I talked to this person, I got better. Maybe you should also go and talk to this person, and so on and so forth. Okay. Any other discussions, any other questions? We don't have time for it, but I mean, yeah. Thank you very much.
The average time it takes for a physician to interrupt a patient. Any guesses? How many seconds does a physician take before they interrupt a patient? 7 seconds. Someone said it. The hospitalist. Except if you're Dr. Mustafa Bhai, who may be at 7 minutes. So he's a saint. They do good work.
I get more time.
I think we all need to get trained to be more available for these issues because there's not enough of them. So with that thought, you're going to come back and teach us some more. Thank you, Mustafa Bhai. You did the last session with a lot of grace and fervor, so thank you. Guys, please take a break. Aap logo sara chovaje, please ballroom ma pujjo. This is now, we're just going to have fun for the rest of the evening. We're going to play Jeopardy and make fun of each other, and you do not want to miss that. So, thank you.